Hello everyone, so today we're going to talk about OB anesthesia because I just finished my OB rotation and I really loved it. If you follow me on Instagram, you saw some stuff from it and you know that I loved it, so I wanted to talk about it a little because people had a lot of questions. First of all, I'm in a different space filming because my house is chaos right now. We have 3 dogs right now and they are playing and running around, so I didn't even try to film down there. I just came straight up here. I figured it'd be a lot easier. Really quick before we dive into this video, I wanted to explain why I didn't vlog when I was on my OB rotation. So a lot of times I'm able to vlog on call shifts and things like that. I vlog when I am off the clock and when all my duties are done. So I do it very safely and without violating any rules. But during OB, I just didn't feel comfortable vlogging, so I just didn't. I felt like we were very busy. I had a pager that was going off a lot and we were running to do stuff. We shared a little room that was attached to the OB C-section suites, so there was a lot of people in and out. It just did not seem like a good time to vlog, so I just didn't worry about it during my OB rotation. I decided I would remember everything I could and then tell you guys about it in a talking video. Okay, so let's start talking OB. My OB rotation was about a month long. I just finished it. It was in a level 1 hospital system, so we got a lot of high-risk pregnancies and just complicated things there. There is a NICU where I did my rotation, so that also enabled us to take more complex cases, and I really loved it. I was actually surprised because in nursing school, I didn't love OB that much. I enjoyed the class, but the clinical wasn't really my thing. I didn't really mind it, but I definitely didn't want to work there. Well, OB anesthesia is a totally different thing, and I absolutely loved it. I loved doing all the skills. We are responsible for C-sections, both under regional anesthesia and under general anesthesia. We do spinals and epidurals, and we start IVs a lot in triage and things when there's hard stick patients. My favorite thing was probably doing epidurals because it was really awesome to be able to give the women some pain relief, and also it's kind of a complex skill, so it was really awesome to learn and become confident in, as confident as I could be with just a 1-month rotation. It was also the skill I was the most nervous about. I don't know why, but just sticking things in people's back before I'd actually done it and understood it made me nervous. So I read a lot about it before I went to my rotation. I made a bunch of notes that I could carry with me in case I forgot something or wanted to look them over before I did one, and just learned as much as I could, and then also listened to the people who were teaching me a lot. Everybody has a different technique, so learning all the different techniques was great. And by the end, I felt much more comfortable doing epidurals. Okay, so now I want to dive in a little bit more about what we were actually doing on the anesthesia side of OB. So first of all, C-sections. We're present for all the C-sections. We do a spinal if they don't already have an epidural. So a spinal will provide anesthesia for the C-section, and if they have an epidural, we dose the epidural. And there's also the chance that it'll be a general anesthetic if it's an emergency or if we have like a failed spinal epidural, which can happen. So things like that would cause us to convert to a general to protect the baby and the mom, obviously. I'll talk a little bit more about spinals versus epidurals in a second, but first I want to talk about what we do during the C-section. So aside from the spinal and epidural, we do pain control if the spinal and epidural is inadequate. We do anxiety control. We give medications such as Versed for moms who are feeling really anxious. We try not to do this too often if they don't need it because it can cause some amnesia, and obviously people want to remember their time during their delivery and seeing their baby for the first time, but if it's an emergency and there's a lot of stuff going on, the first priority is the safety of the mom, and sometimes safety can include anxiety control. We always explain what we're giving and give them the chance to say yes or no. Another big thing that we treat during C-sections, even routine non-emergency sections, is nausea and vomiting. Spinals, as well as all the movement in the abdomen, can cause severe nausea and vomiting, so we treat that up front and during the case. That's a huge thing that we deal with almost every C-section, trying to prevent that. So we use Zofran, obviously, as our first line, and there's some other agents we can use if the Zofran is not effective. If we're doing a general, or for some reason we need to convert to a general, it's always an RSI, which means it's a rapid sequence intubation. That's sometimes a tongue twister. But it's because we always consider pregnant women to have a full stomach because of the intra-abdominal pressure from having their uterus expanded by the baby, obviously. During a C-section, after the baby is out and the cord is clamped, we also give Pitocin, which causes the uterus to contract and help prevent bleeding. So one of the big things we watch for during a C-section is bleeding. That is one of the main complications, hemorrhage or bleeding. If the uterus fails to contract and just becomes boggy, that can be a big sign of bleeding. So we keep an eye over the curtain, keep an eye on the uterus, see what it looks like, communicate with the surgeon, and keep an eye on the blood loss. Regional C-sections can be complex because we're doing all the anesthesia, but we're also being emotionally available for the mom and the dad because oftentimes the dad is in the room. If something's going on with the baby, the parents are very panicky, so we have to be there for them. Often the mom is very anxious because obviously she's having a surgery and she's awake, and especially if it's her first time. And oftentimes the dad is very anxious too because they can't really do anything. They get sometimes dizzy or look over the curtain and then feel faint. So there's just a lot of stuff going on behind the curtain that we're dealing with. But that's part of it that I actually like, because I do like interacting with patients. So I like being able to be there for them and talk them through everything and just be emotionally available. Also, another reason OB is kind of different from everything else we do is because it's more of like a choice. They decided to have a baby and it's more of a happy time. So it's less of like a sad time where you have to have surgery because of something that you didn't want and didn't have any control over. I just really enjoy seeing people meet their babies for the first time, and it's really cool. Okay, so now let's get into talking about spinals and epidurals. So we use spinals for C-sections only. We use epidurals for labor and delivery analgesia as well as C-sections. So a spinal is also called a subarachnoid block because it goes into the subarachnoid space. Something about spinals is they work quicker, they're a little more intense, if that's the right word. While epidurals work slower, spinals can cause more hypotension. Epidurals can also cause hypotension, but a little less than spinals. Epidurals go into the epidural space, obviously. That's a potential space, so it opens up when we put something in it, but normally it's just a potential space that's there. Now, in my opinion, epidurals are harder to put in the spinals because spinals just go into one spot, you confirm with CSF, you inject the local anesthetic, and then you're done. Epidurals requires getting into the epidural space, which we use certain techniques for to identify that space. You don't want to go too far, or then you are in the spinal space. And they also require threading a catheter. We do continuous dosing through epidurals as well as bolus dosing when needed. So it's just a little more complex pain management than a spinal is. We do epidurals in the patient's rooms when they're laboring. We do spinals in the OR. So if you think about being in a patient's room, it's kind of a less controlled environment. There might be family in there, the patient's having contractions, which we try to work around. It's just a lot going on in those rooms. And so it's just a really good experience to be able to do stuff out of the OR because it gives you exposure to different things when you don't have everything you're used to. We bring a cart along with us that has all of our emergency airway equipment, our emergency local anesthetic toxicity equipment, all of our local anesthetics, and our epidural kit and things like that. So we do bring a cart around that has everything in it, but just being out of your comfort zone is always good for growth in the clinical area. And also, I just learned so much about local anesthetic dosing. I had read it in the books before, but local anesthetics are dosed kind of differently than regular drugs. Most of our drugs are based on weight, but local anesthetics are based more on volume and which one you choose based on how long you need the duration of the block to be. It's very complicated. There's a lot of different choices. You can add things to them to make them work quicker and make them last longer. So just being able to experience all that in real life instead of reading in a book gave me a lot of insight and really helped solidify the knowledge that I had learned in my lecture. And I just have a so much better understanding now of everything that goes into local anesthetic dosing in spinals and epidurals. Now, the last thing I wanted to touch on was the mom versus the baby who's our patient. And this is kind of a complicated one. A lot of people ask this, do you take care of the baby and the mom? Yes, we take care of the baby and the mom when the baby is in the mom. So the mom is always our first priority, and keeping the mom safe keeps the baby safe. But once the baby is out, there's a team of nurses there and a doctor if needed that take care of the baby. So once the baby's out, the mom is still our patient, but the baby is somebody else's patient. If the baby needs intubated or something like that, either the pediatrician or another anesthesia person will come in and do it because we're taking care of the mom. Now, I can imagine that in some rural hospitals or emergency situations, the CRNA or anesthesiologist who is taking care of the mom would end up intubating the baby if that was the only thing going on. But I have not experienced that. As I said, I worked in a big level 1 center, so there was a lot of support and we didn't run into that problem. But I think there could be very unique emergency situations where you ended up securing the airway for the baby and taking care of the mom. I'm not really sure, that's just my opinion. I haven't seen it happen or heard about it, but I think that that could happen. Okay, so that is it for my OB video. I hope that you guys enjoyed it. I hope that the different room and all the cars going by and sounds didn't distract you too much, but I really appreciate you watching. I hope I answered some of your questions. If you have any more questions about OB, leave them below in the comments and I will answer those for you. As always, I hope you have a great week and I will see you next week.